we want to have a conversation that, is currently ongoing, and is not a conversation that started like yesterday. It's a conversation that started in 2019, and we will be sharing an article in a few that was done by Kwame Owino, my colleague, just on, at that point, there was an interest in having a private wing built at the Kenyatta National Hospital. And then that backed the conversation around privatization of Kenya's health sector. So this morning, we want to unpack what privatization of Kenya's health sector means, and just look at the pros and the cons, and just unpack the whole concept of privatization. And today we will be hosting with us, of course, Kwame Owino, who is my colleague and the CEO of the Institute of Economic Affairs. And we also have, who will be speaking to the economics of privatization, because as we are having this conversation on privatization, do we understand the background of privatization? And of course, there has to be some economics around it, because we are the Institute of Economics Affairs. So what we do is unpacking the economic aspects, the economic concepts of every idea, of every issue in this country, so that we are just not looking at it from a social aspect, but we're also looking at it from the socioeconomic aspect. So Kwame will be unpacking for us just the economics of privatization, so that we understand what we are talking about. And then we also have Dr. Miskela Dennis. Miskela is the National Deputy Secretary General for KMPDU, KMPDU. So he will be taking us through the status of Kenya's health sector, and then introduce to us this conversation on privatization of the sector, and why the conversation is being had, and whether or not it's a conversation that we should be encouraging, and why, if so, we should be encouraging it, and if not, why it's something that we need to sit back as a country and reconsider. So a very quick overview on why privatization, and why we think it's a conversation that we should have. And as we have it, we should have it with a lot of clarity. So what really is privatization? So in our understanding, privatization is just the process of transferring ownership and control of a public asset to the private sector. And it's a concept that is not new globally. Across the world, we have seen this privatization concept being embraced. And the reasons why it is being embraced is people cite reasons such as privatization increases efficiency, privatization increases and improves service delivery, and of course, it reduces the burden on the government, government spending and the government resources. So the big question then is it really the direction that we as a country should actually be considering? And as a matter of fact, as we have this conversation, we are well aware that the Kenyan health sector has been suffering numerous challenges. So we have challenges within within the health sector, such as inadequate funding. We have shortage of health workers. There is poor infrastructure, lack of essential medicines and equipment. And we have seen a trend where the government is struggling to provide adequate healthcare services to its citizens. And more so, if the urban citizenry is complaining, we can imagine what is happening in the remote and the marginalized areas. And the conversation around privatization is, those who are for it are saying that it would improve the efficiency of the health services by introducing competition in the sector. It will reduce bureaucracy and also increase accountability. How true that is what we want to unpack today. And of course, again, the argument around privatization is that the private sector seems to have an incentive, which is to make profit. And so because of that incentive, they will work towards improving and ensuring that the services offered within the health sector are worth our time, and we get value for our money. How true that is, we want to unpack today. And then we have those who are saying, well, why do we really want to consider privatization? Have we looked at the component of it leading to commodification of health services? And then widening the inequality gap. So are we with privatization, are we in a sense pushing health services to those who can afford it, you know? So there's an aspect of affordability that comes into question. And then there's also an issue of access, because those who are arguing not for privatization are of the argument that we will be reducing access, especially for those who will not be able to be able to achieve or have access to health services because of increased prices within the health services, and so on and so forth. So for us, we want to just unpack all these concepts that everyone is talking about when they're speaking about privatization, and try to explain to you what really is privatization and what, as Kenyans, we should be having at the back of our minds when we are speaking of privatizing our health sector. So like I said, Kwame will speak to the economics of it, and then Dr. Miskela will come and just now unpack the realities on the ground. So without further ado, I would like to invite Kwame to start us off. And before he speaks, I would just like to remind us that we will have all of us on mute until the question and answer session, where we will unmute all of us, and then we will have you asking questions. And in the meantime, if Kwame or Miskila says something that you think you need a clarification on, please make use of the chat box. You can indicate on the chat box, and then during the Q&A, we will revisit and have them respond to it. So once again, karibuni sana, and Kwame, please take it away. Thank you.
So the point is, we are supposed to speak about the economics of privatization. I am conscious that we are speaking about privatization in respect of healthcare, but maybe it's good to just establish some basic facts about what privatization is, and Winnie's defined it. Now, so when you talk about privatization, what Winnie spoke about is a simple definition is basically to transfer property or assets owned by the public sector, which is government, into private hands so that they are run, they're managed within a market structure. So that's just basically it. Now, why is, so how does an economist or a student of economics look at it? You look at it in this way. One of the things that economists have learned is that markets are a good way of organizing economic activity. So basically, if you have a market, it allows for competitive prices to be revealed. On that basis, competition occurs, and because competition occurs, efficiencies are driven in terms of how much resources are available. Prices come to reflect the most effective and the most competitive points. And that necessarily generates two things. It generates a surplus for the consumers because they get the best quality of service for the lowest cost. We assume that competition exists for that good or that service. In this case, we're speaking about markets. So among the reasons why you could consider privatization, therefore, is one, because obviously of efficiencies. Sometimes efficiencies arise when you privatize firms or when you privatize an activity. You allow for private sector people to come in and to compete. So efficiency of market systems in providing some goods and services, I think, is an indisputable part of modern economics theory, but also practice, and obviously empirics show that. I need to come now to the fact that healthcare and health services are a form of economic activity in the sense that they are inputs that go into providing a health service. So for instance, if you're going to provide a health service, say, for instance, some treatment for malaria, let me use a typical example, you will obviously need a facility, which is probably a doctor's office or some office that allows a physician to be able to conduct diagnosis. There's equipment that is required to conduct that diagnosis to find out that a patient would have to be examined. After that examination has taken place, which is in itself is both the input, the professional input of the physician, perhaps an assisting person in the form of a nurse. There might be a lab or a laboratory assistant or professional who will be able to extract blood and actually test whether this patient is necessarily suffering from malaria and not something else. So that is, his treatment can then be designed on the basis of that diagnosis. So as you see, each of those, it requires the inputs of various professionals. All those have economic consequences because you need the training of all these people, you need to provide the services that allow, or rather the equipment that allows for that treatment to take place. And at the end of it, obviously, some treatment will be administered, and this patient might be given some prescription, whether in the form of some drugs or some applications that will be made by a professional in output. All input, all those require resources, whether it's the training of these professionals, whether it's the physical facility in which that treatment is provided, whether it's the inputs that are made in the diagnosis and the treatment care that is provided, obviously, up until this patient is fully recovered. So while those occur in a social environment, they are actually economic inputs because they require resources to be spent. Now, if those resources are being spent, then a market system might give you the impression that they'd be applied in the best way if some competition and these professionals applying them understand that the alternative uses for all resources, because the alternative uses for all those resources, if it's going to be spent, whether it's government or somebody else who's paying, those resources need to find the best outcomes. So the pressure of competition would allow for this facility that is providing this service to ensure that it applies the best alternatives, and it uses the best inputs available to it to get us the best outcomes. So those outcomes would then be efficient. So it's that efficiency that you chase through a market system, and which privatization might allow. On the other side, sometimes when facilities are available in government hands, they don't always have the pressure of competition. Why? Because it means that often government is a monopoly or the biggest provider, and the pressure and the economic incentives faced by people who provide those services might be entirely different from a different person providing those, because they know they need to provide good value for this patient so that this patient could pay, or whoever it is who's paying would justify that treatment. Why? Because of the possibility of exit from that custom. So basically, a client or a patient would choose about whether to go to one person or the other, and the outcome of that treatment, or even the facility in which it provided, will provide an incentive for them. So provided, what happens in a market system is that the customer, if you may call it, in this case, the patient who has a choice, gets to choose where they spend their money. So in other words, they are voting with their money, or voting with the resources that they're prepared to provide. That provides an incentive for efficiency. That's not always possible in the public sector. I say this in a guarded way, but it's true. In the public sector, sometimes when there's no pressure because somebody does not see an alternative, a public sector person working in the public sector, for instance, who has certain guarantees of work, may lack resources that are necessary to input into that service. And so patients may actually have different outcomes depending on whether they're visiting a public hospital or whether they're visiting a private hospital or another one. So privatization might be essential, or one of the ways of providing that. Now, privatizing in a health service is actually a very touchy issue for obvious reasons. You're dealing with human lives. But more importantly as well, the government of Kenya spends the biggest share of resources and has the biggest employment of professional workers who provide health services, who themselves have challenges within the public sector, do the best job that they can, not always, but do the best job that they can under that. And therefore, privatizing healthcare is something that many people have either ideological or real fears about, because they believe that doctors or professionals or the treatment and care should be provided on the basis of need and not necessarily on the basis of an incentive to income. The belief being that if somebody works in the public sector, they don't face a direct income incentive to provide one treatment or the other. But if they work in the private service, that would be. Now, that's not always true, actually. It's one of the many reasons that are cited for why privatization should not take place, but it is debatable. In Kenya, privatization takes place and is guided by the privatization law. Now, there's a new draft of the privatization law, which is supposed to be coming in. It hasn't been sent to Parliament, fully discussed and received presidential assent, but there's a draft. But let me discuss what exists. The privatization law in Kenya defines privatization as moving public assets into private hands. And there are various methods of privatization. But it identifies those methods as public offering, which would be to sell shares, It would be the sale of assets, which means you would sell assets related to the public, whether it's assets in physical form or it's other assets. I mean, it's obviously assets in physical form or it's in the form of property would be sent out, or any other form of privatization that is approved by the Cabinet Secretary, in this case, the Cabinet Secretary for Finance. So we have stated that markets are a good way to organize economic activity. The government of Kenya manages a lot of assets related to public service, public service delivery or delivery of services related to health. We also have that distinction that there's national government responsibilities in the provision of health services, what we call frontline health services, and they run all manner of clinics and employ a lot of doctors and professional workers in health. On the other side, we have a private sector driven service who provide services. They run hospitals, they run clinics, either as corporations, in some cases as practitioners, and we know all of them across the entire health service delivery channel. So it could be whether it's physiotherapists, whether it would be dentists, dental care, professionals providing dental care, physicians of one kind or the other, all the way to nephrologists. There are some in the public sector, there's a private sector. So in Kenya, we have a dual system for health services, in which some, and a bigger part of it, a proportion of it is provided for public service through the public service. National government and county government have shared responsibilities and different responsibilities in the provision of healthcare. And then we have a private sector set of institutions. Now, what I'd like for us to distinguish about the privatization of healthcare is essential, because when we discuss privatization, we ought to be clear about what we mean by privatization. In Kenya, in addition to privatization to provision of public health services, the government of Kenya is involved very heavily through the National Hospital Insurance Fund, which is basically the health insurance portion of health service provision, where the government has established a facility called the National Hospital Insurance Fund, which collects money from working people or others who contribute. This is a health management, services are managed, and that provides an option for Kenyans to be able to actually provide services, access services, of course, with certain limits based on what the contribution is. On the other side, there's also health services insurance, which is basically health insurance, which people can purchase in addition to the one that is mandatory for health under the NHIF, and which some small set of Kenyans use for the purposes of accessing healthcare. And these two work. So we have a dual system which is all mixed. So when we ask ourselves what privatization in healthcare means, we need to be able to distinguish between the provision of the service and the payments for it. There are countries in the world in which payments for it might be mediated to a public facility or institution, and there are others in which all health services are run entirely by the government. So if you look at the national health services in the UK, for instance, it's one example in which all health, or rather, a majority of health services, I need to correct myself, are provided through the national health services, where government employs most of the doctors or most of the physicians and health workers, and then provides to the population on the basis of citizenship, that kind of treatment. And so this is funded through taxes. In other jurisdictions as well, government simply takes care of the health insurance by providing money through taxes and contribution from workers. On that basis, buys insurance for workers. Buys insurance for and provides cover, which assures people that you can seek treatment, whether in the public or other facilities that get that. The US as well has a mixed system. We know about Obamacare and its various problems and challenges on the one side, and there are also people who have health insurance and all that. So what I think in Kenya is essential for is, it is still possible because we have very decent health services provided in some cases through the public services. In some cases, though it is difficult to actually say that health services in Kenya match, public health services in Kenya match what is provided for in the private sector. When privatization is spoken about, one of the things we care about are people with low income and people who suffer from chronic diseases. That kind of treatment tends to be very, very expensive. And there might be an argument for providing a publicly funded mechanism for people to reach services and to be able to actually access services. But there's no compelling reason, I state this emphatically, there's no compelling reason why government must own and be the sole the sole operator of health services, health service provision, including some of the services that government already provides are funded on the other side through the NHIF contribution, suggesting that Kenya needs to search for a pretty equilibrium in which government thinks about the most efficient way using resources that are scarce to provide health service outcomes that Kenyans would appreciate, whether it's through the private sector, whether it's through the public sector. But it's clear as we stand right now, the public health infrastructure has services, a lot of money, but whether the outcomes that we see are consistent with what the public appreciates as good value is one that is not. And there's a compelling reason for some health services provided under the public sector to be provided through the private sector, with government funding being part of it. So obviously, this is not necessarily something that requires an abrupt position, because we must proceed on the basis of initial conditions. And initial conditions tells us that there's a significant mix between public service provision on one side, private service provision, and the funding that goes from both sides to the other. So I'll reiterate by saying that it is self-evident that some health services can be provided very well through private sector. Some services that the public sector provides today on health services are very poorly provided or suboptimally, and there might be scope to consider privatizing them. We need to choose very carefully which parts of those that would be. But the overriding interest should be efficiency, allow for competition to drive down prices with the biggest interest on the part of the patient, not doctors on the one side and not government itself. I think if we think about patients, the argument for privatization of some health services in Kenya is a compelling one. Thank you.
Thank you so much, Kwame, for your comments and for just unpacking to us the concept of privatization and the economics of privatization, and just making us understand what really privatizing the health sector would mean from an economic perspective. And also just making us realize that, well, as much as we think of privatizing the health sector, there could be a consideration of privatizing some elements of the health services being offered, and letting the other some of those remain as provisions under the public the government, that is. So it would be interesting to hear from the practitioner, who is Dr. Miskela, to just tell us what really is the status of the health sector, because I do not want to summarize what Kwame has said too much, because I think it was very, very direct. So Dr. Miskela would come in and just unpack to us what is Kenya's health sector status, and why this conversation on privatizing it is actually going on, and whether or not as Kenyans it's something we should be applauding, and if not, why should we not be applauding it? So Dr. Miskela, you have about 15 minutes to just give us your views from a practitioner's point. Thank you.
I'm Dr. Dennis Miskela, the Deputy General Secretary for KMPDU. That is the Kenya Medical Practitioners, Dentists, Pharmacy and Dentists Union. So we are a union that covers for around 10,000 members across public and private hospitals. And our running logo is healthcare is a right. We are motivated by Article 43 of right to healthcare. Not just healthcare, but the highest attainable healthcare. We have to underline that because lately we've been seeing instances of bora afya, sio afya bora. Yeah. So these are timely conversation, Winnie, and I have to thank you for this discussion. You've met, and you know our position as a union is that privatization of healthcare in Kenya is bad for healthcare. And in the next 15 to 20 minutes, I'll be able to put our case across. But just to think that currently just getting out of the COVID pandemic, and we all know that some of the countries that responded best or better were the countries that had healthcare in the public hands. USA, the superpower of the world, lost millions because of what privatization of healthcare in that country has done. Yeah. So there are certain things that we have to understand from the word go. That as we sit here talking about moving a social responsibility to a private hand, you have to ask yourself why. Who is this individual who can out invest government? Yeah, because you have to understand that healthcare is a social function, and some of the social functions in this world should be funded by taxpayers' money. So when you're taking away that responsibility to private hands, then you ask that what are the taxes for? Because we live in a country currently where we like having private solution to public problems. When there is no clean water running in the taps, what do? You buy a dispenser, you buy water bottles, yet that's your right. When you don't have working public transport, what do? You buy a car on expensive loans, you have to use matatus. When the public schools are failing, what do? You take your kids to academies, yet you're paying taxes. Yeah. So basically, if you look at how Kenyans were taxed, when you take the 30% off on pay, then you take the 16% again on VAT, then all those other road levies, income, fuel levy, basically you end up remaining with probably like less than a half of what you're working for. Yet within this less than half is what you want to take your child to an academy. You want to buy water for drinking. It's the same thing you want to use to go to private hospitals. It's terrible. And lately we've seen an instance where almost most of us here who work in the private sector, the first thing that your employer does to you, apart from your salary, they give you a medical card, a private insurance card. Where did you get to this point that even something that your taxes should be paid for? We have countries where you are taxed almost 40% plus, but then government takes the responsibility. Like in the UK, we have the NHS covering for the health. Public schools are free. So that when you choose to go to private, let it be a choice because you have extra. But currently, we are going to private or seeking private solutions in all sectors because that is where quality is. If you dare drink water from that tap, you can probably get dialysis. If your child goes to a public school, the chances of them competing fairly is almost nil. And that's why we are putting a case today against privatization of healthcare, knowing very well that as a union, our core mandate as a social institution is to promote the public good. Our clarion call is we leave no one behind. So any system, any policy that brings inequality and drives other people to stay behind is something that we're going to be against, especially on something as basic as healthcare. Yeah. A child who probably goes to public school and fails has another chance. Yeah. Somebody who is a matatu will probably suffer some inconvenience but will get to work. But that poor person who fails to get the quality healthcare because they couldn't afford it, there's no second chance after death. Unless maybe you come from Shaka Hall and you have other beliefs with a light touch though. The other issue that as we talk about privatization, I want us to look at it from the point of thinking about those who are poor, the vulnerable, those who live in the fringes of the society and the margins. Yeah. Don't look at private healthcare and you see the big facilities you see around here owned by billionaires. Think about those small facilities you see in the estates, in the slums, and their impact in the quality of healthcare. So without further ado, let me start moving. So Kwame has captured this quite well, where privatization is just the transfer of ownership or responsibility of healthcare services to a private hand. I've quoted there and I'll share the references later. Yeah. So sometimes it can happen that you have the entire healthcare system being run by private guys, or you have an instance whereby you've outsourced maybe the pharmaceuticals, the imaging, the laboratory, yeah, or the doctors. So over the decades, there are different countries that have tried, yeah, different models, trying to restructure how we deliver healthcare. There are those who have redirected the entire government policy towards public institution now being privatized, and there's those who have then put strategic investments in healthcare. For example, what we had in Kenya here, the MES program. Yeah. Some will argue, as Kwame said, that it increases efficiency. Yeah. While some of us say that feel like a threat to public institutions. Yeah. And also brings about inequality and also hinder the government's role in controlling some of these social services. As we got to know during COVID that matters of healthcare are almost matter of national security. Yeah. So a sick policeman won't be going to work literally. Yeah. Yeah. You've seen issues about people starving and all that in Shakala dying in the hundreds. You've seen the hand of government, the security apparatus. So that's how healthcare is important to us. That the moment you surrender that, is like then you're moving to a point where we're going to be surrendering probably even our armies and the police. That's how serious this thing is. I want to give a case for Australia, then we'll come and compare it with what you have here. Yeah. So over the past 2 decades, the Australian healthcare sector has been restructured, just as I said previously, towards privatization. Yeah. And this has structurally reshaped the healthcare in that country. In Australia, you find that instead of having this, what we have like in the UK, where you have these public hospitals and then maybe an option of private for those who want to attend that, you are going to outsource that service completely, where you have doctors, different practitioners, investors opening small clinics and seeing patients and then charging it to the government. Yeah, so all you have to do is open up a facility and then sign a contract with the government to provide healthcare in that particular town or region. Yeah, this kind of practice has been found to, first of all, be very, very expensive. Yeah, because you know clearly that I always like using this quote that it is not out of the goodness of the butcher that he sells the meat. So nobody is going to open up a private hospital because they love you so much that you live long. They are in it for profit. And what do? You always have to increase your margins of profit every other day. It becomes very expensive. And of course, the self-interest, yeah, where these facilities, it's more about them. The interest of the patient is no longer a priority. Yet we know that the practice of medicine from the days of yore, it was always about the patient, the doctor, and the patient's interest always superseded any other interest. Yeah, yeah. No, there's this guy who keeps on saying in Twitter that the patients don't care how much you know, but they want to know how much you care. Yeah. So as a doctor, when my business only is with the patient in front of me, as I treat the patient, I should never care about this middle person called the insurance company telling me that I cannot use original drugs, I cannot use generic, or asking me that I cannot do a particular test because it's expensive, I have to use an alternative one, or some manager telling that this clinic has to make profit, so I need to move the queue for expensive drugs. That self-interest should never be in something like healthcare. Of course, the issue around even a patient choice, you get sometimes like even in a room where a certain region, they only accredit a certain facility to provide healthcare in that region. So I had an instance where this guy opened a clinic and he wanted to be accredited with the insurance companies to be able to. This insurance has already approved X number of facilities in that place. We cannot add anymore. So yeah, and also that's the less accountability. Yeah, when you have this social function, this government responsibility being given to a private person, yeah, who are they accountable to? Yeah, they're only accountable to the owners of the capital, not the government. And with this, then there have been lower control of government over some of these health policies. Yeah, you have facilities in this country, in these estates, calling themselves level 4s, but when you go there and the staffing norms, the number of doctors they have, the number of services they offer, is not even how they pay their workers. So that kind of control is lost. Same with the Australian state country example. Yeah, but despite the evidence showing the negative impact of this privatization in that country, the government of Australia continues to allow for corporate control of the healthcare. Yeah. So let's get to a case for Kenya. Yeah. we see that Kenya, we still have healthcare as a right that's provided for in the constitution, and a right that cannot be surrendered to anybody else to provide. These rights must be secured and provided for by the government. Kenyans are the rights holders. Government of Kenya is the duty bearer. There's no other person that we expect to provide that.
As
Yet,
Dr. Miskela tries to find his way back in, I'm not sure, Kwame, you're still here?
Yes, I'm here. I'm here.
Yeah, because I know Kwame should be going in for a meeting. We have a question. We can just have a conversation on this question as Dr. Miskela tries to find his way back in. So Kwame, there's a question for you regarding the conversation you just had with us. And Adrian is asking, on this market-based model, do you see an outcome like in the US occurring whereby different players, as the insurers, medical facilities, practitioners, and the like, fight for their interests, and the only person losing is the patient? So you could be responding to that.
The question you're asking is, on this market-based model, do you see an outcome like in the US occurring where different players, insurers, medical facilities fight for their interests, and the only person losing is the patient? Well, I don't know where people don't fight for their interests, because if you have, so let's compare that. Let's even take your claim as given that people are fighting for their interests, and let's come back to Kenya. A couple of days back, you had a notice that was given to county governments and to national government that some doctors would, some health workers rather, not doctors, health workers, inclusive of doctors, would stop going to work because they did not have tools. And some of them, of course, we also know that in the other places in which doctors have failed to go to work because they did not receive some work. So what that tells me is people know how to take care of their interests, and they're going to take care of their interests whether you have a privatized form or you have a public sector form. So that interest question is not, in my view, peculiar to health systems that are run by the power, that are privatized or have a huge private function. I think my view here is that we need to concentrate on the patient. What do patients want? And if a person is prepared to spend his or her money within a public health system, that's fine. Because the public health systems, we should not think that public health systems are necessarily free. They're simply run by doctors and health workers, and they are probably and sometimes run within a facility owned by government. That doesn't mean it's free of cost. So I think that's the useful thing. So the point I'm responding to is that regardless of what health system you run, people understand what their interests are. And I'm saying the superior interest that the public should be interested in is the interest of the patient. And if you provide services that are based on providing the patient with expanded choice, with competition, with efficiency, and people who actually understand what patient needs as opposed to what is available for them, then you give patients an opportunity. That's what privatized systems give you, that choice. Now, I also wanted us to separate the question between who pays, which is the funding function, from the provision. So already in this country, there are services consumed in the public sector, in the private sector, for which the public facility through the NHIF, for instance, pays. So, for instance, for dialysis machines, I think it is allowed for people to seek some treatment. Of course, it is limited, but part of it is paid off the NHIF fund. We also know that for hospitalizations in in private hospitals, a level of the bed cover is covered, is borne. For those who have NHIF cards, is borne by the public facility, or at least the institution that has collected some taxes or collected some contributions. So it's a mix and match. All a privatized health system does is gives the incentive for the patient to be placed in the center. And there are many forms of privatized health systems. There's not a single one. So that's the idea. I'm also saying I see also Dominic saying that the market solutions for private healthcare have worked in accessibility of drugs through private firms selling wholesale drugs. That's true as well. Yes. So basically what Dominic is reinforcing is the idea. I am not suggesting this is the perfect solution. I am saying that if we place a policy that is responsible for the health of the patient and not necessarily about doctors and ideologues like Adrian, who seem to think that they control people, that's fine. But I'm saying if you give patients choice, and government could also provide those services and have patients choose whether they want to go to a private facility or not. Those are the things that a more efficient, a superior market system will give you. There's no perfect system that solves all problems. So in the US, yes, sometimes drugs, mishaps takes place, but in the US, the laws allow you to get emergency treatment from any facility as a covered right. That's the question that I was responding to. But since we have our second respondent, our second presenter here, let me allow him to come back and I'll be back for any other questions. Thank you.
Thank you so much, Kwame. So, Dr. Miskela, welcome back. We're sorry about the technicality you experienced. So you have about 10 minutes to make your case and just bring us back to what we were discussing. Thank you.
You've seen that in Kenya, there have been intentional push of Kenyans to privatize healthcare. Yeah, by increasingly underinvesting in healthcare. Yeah, the government signed the Abuja Declaration almost 20 years now has passed. Yeah, they have not gone anywhere close to 15%. In fact, the budget has been dropping for healthcare. What does it do? The quality of the healthcare services in the public health sector then drops. You have longer waiting hours, you have drug shortages, the labs don't work, the imaging don't work. So what does it happen? People then move to private hospitals, not because they have the money or they can afford it. No, they go because your choice between living and dying is between going to a public hospital and a private hospital. Yeah, so we have what we call now de facto privatization. And when people move there, don't think about the private hospital being like the big hospitals, the Nairobi, the Aga Khans and all this. No, think about those private for poor clinics you see in the estates. Yeah, you've seen in the slums, you've seen in the lower income areas of residence, you've seen this poor quality private hospital that even has worse services, but since they have probably shorter waiting times, people move there. Since people won't have to be sent out to do the imaging, they'll go there. That's one. Two, is that there have been policies put in place that are embracing the private sector. For example, the Kenya Health Policy 2014-2030, which seeks to strengthen the role of private sector as both a financier and provider. Also, we have the Kenya Health Sector Strategic Plan 2018-2023 calling for the same. Yeah, we have this large-scale government contracts with private sector. We've had some clouded, secretive PPPs. We have issue about the MES program, the managed equipment program. You saw the scandal, 67 billion shillings later, the equipment don't even belong to us. Yeah, we have also that when they are building, they are given or buying equipment, they're given tax incentives. We don't know sometimes. The little mama now covered in private hospitals. Yeah, the other day you had the teachers being taken to see some private clinic that anytime a teacher falls sick, they have to go to a specific clinic to be covered. Yeah. Right now, if you look at even at NHIF will move to cover even private hospitals. The worst thing that over 60% of the rebates, NHIF is publicly funded. You collect almost 140 billion annually for NHIF, but more than 60% of the rebates. In fact, I was just reading some document about over the top 10 rebate hospitals just received the rebates from NHIF. Only 2 at public hospitals. That's KNH and MTRH. The other 8 are all private hospitals. Yeah. You've had even the issue around right now, public service servants being moved to private insurances. What does it mean? There's no public hospital that takes public insurance. It means that when you have the police, as a teacher, as a doctor, if you have a private insurance, you go to a private hospital. You get that? So that's how government has intentionally pushed us to this. In fact, just looking at some of the data, the private hospitals have grown from 33 to 42% from 2013 to 2020. Yeah, the private clinics have they're really grown 6 times and covered the market share. Yeah, the proportion of the outpatient visits in Kenya right now in a private facility has increased from 17 to 25%, and you can see all that. Basically, you can see the growth of the private sector, but yet this never means that the quality of healthcare has improved. We still have very, very bad indicators. The maternal mortality are still high. Yeah, and why is this growth? Because there's certain players that are coming to the market, the World Banks of this world, the international financial institutions, the IFCs, who are now the philanthropic organizations like the Bill and Melinda Gates. They come and they intentionally invest in private healthcare. There's a hospital that was recently opened along Kiambu Road by the president, built by IFC. Yeah, you have policies that are intentionally being pushed down our throats that favor private health sector, and so much more. Yeah, you have contingent loans being tied to certain things that must be done to promote the private sector. Yeah, so this unleveled playing field is no longer available. World Bank in 2010 provided $90 million in loans to kickstart the Kenya's public-private partnership. So you can see all these things being put in place to push us towards public healthcare system. But the argument about the efficiency is not the truth. Because, for example, the managed equipment scheme, the MES, which IEA recently issued a report and even presented around the controversies around it. If you get a chance to lay your hands on the report of the MES, scandalous. I know of a county where they put a renal unit for which for 2 years didn't work because there was no nurse, no doctor to use it. But they didn't care, they already pocketed their money. Together. So that efficiency is not only the truth. In fact, if anything, for me, I call PPPs and all those are just conduits for profit and for corruptions. Yeah. So that's just the same thing. Then, so we have to say that what is the role of even the so-called philanthropic institutions that we now have in Kenya? Yeah, we are having programs from Kenya Melinda and Bill have talked about that. Yeah, that are intentionally pushing us towards that. But then if you've had the issue around the vaccines, the COVID disease was here, the role of the same philanthropists around the creation of the vaccine and the distribution and the inequality and apartheid around that, we all are aware of that. Yeah. We have examples, things, Philips Healthcare, which are all engaged in PPP, and the scandal around that. Even some of these so-called private healthcare are owned by public servants. You'll be shocked if you knew that one of the senior ministry officials was owning one of those private facilities. Yeah, you have governors owning private insurances that they take the public servants' money to. So that conflict of interest has really made work so hard. And it's not just a local problem. We have even global bodies, the Texas Pacific Group, which now literally came to Kenya, bought all the middle-level facilities, and now running them. Yeah. So people ask, why is this certain interest now in privatizing healthcare in Africa? It's only one reason: money. The McKinsey company clearly says that the huge business opportunity for healthcare in Africa, both in pharma and the service and the care provision, almost estimating it to be around 40 to 65 billion. And that's why you see all these certain interests coming from all over the place. Yeah. And what are the impacts of this privatization? I talked about high cost of healthcare. The out-of-pocket expenditure for Kenya has risen by 53% for the period that the privatization of healthcare also increased, according to the report by Haki Jamii. Yeah. If you look at even just breast cancer screening, if you have to compare how we screen breast cancer in the public hospital vis-a-vis the cost in private, it's way expensive, almost 4 times. Even for the diagnostic procedures, an ultrasound in Kenyatta at 1,200, you cannot compare across the road, almost 3,500. So the cost is out of this world. And for a country like us, which is a struggling economy, that's really crazy. There's a talk that you're just one major illness away from poverty. Yeah. The quality. people talk about that the private sector, the equality will improve and all that. But no, that's not true. As I said earlier, that the rights for the poor, the private for poor facilities have shown even worse because they employ less qualified because they have to pay them lower, they have to maximize the profit, they have to buy probably lower quality drugs. There's no supervision from the government agencies. So the quality is never true. In Kenyatta, some of the things that we try to, the measures we try to fix, the referrals come from these private for poor facilities in the low income areas. Yeah. When you, even the draining of public coffers, when you use publicly collected taxes to invest in the private sector, this trouble, because imagine if the 150 billion NHIF collects, if you were to take that money and you just invest half of it in improving public hospitals, building better, employing more, restocking more, the quality will be out of this world. But all that money, we are mopping it up, it's going to be compulsory now, mopping it up and taking it to a private person to just profiteer and pocket it. You know, between 2016, 2017 to 2019, 2020, private facilities received 82% of the NHIF outpatient benefit and 64%, as I said earlier. These are despite almost 80% of Kenyans seeking healthcare in public. So can you see that how that balance is off, where you have more people going to public hospitals, but this NHIF publicly funded institution are refunding more to private. And the saddest thing is that even for the rebates, when you do a cesarean section in private, whatever is paid for is way higher than what is paid to a public hospital. Why would you explain that? A cesarean section is the same. Why would it cost 10,000 in Kenyatta and cost 50 or 6,000 across the road? That's the question we should all be asking. Yeah, you've seen the billions. Yeah, and even just the kind of fraud that is being lost to NHIF by the false claims. Because you know, this money, when you claim it in the private sector, you're going to be pocketing it. So there's the fraud, the false claim, almost 10 billion shillings. Yeah, you have no motivation to do that in public hospital because as a doctor or a healthcare worker, the money will be going back to government. So why do you have to do the fraud? Nothing. So that's some of the challenges that we have to work out. The MES, I keep on saying that because when people give out their taxes, they must get the value for that money. It is wrong that in MES we spent almost 60 billion and we have nothing to show for it. The 7 years have elapsed, the contract has ended, and you're hearing people talking about renewing it again. How? 60 billion later, these machines still don't belong to us. Yeah? And even the secrecy around it, up to date, people, nobody has seen that the MES report, the contract, because it has, some of us have been able to lay our hands on it discreetly, but it's scandalous. When it finally gets out of into the public, I think Kenyans will have to be very angry around that. Yeah, I talked about the safety issue and the regulation. Yeah, the misaligned incentives where you have private providers focusing on the profit, yet you are still giving them incentives. Makes no sense. Yeah. As a union, our main issue with them also is around the poor working conditions, because some of our members who work in private hospitals, they work long hours, they are not paid commensurate to the people in public sector, they don't have leaves, the kind of pressure they're being put for on to you see a patient who probably need to be in outpatient, you're told no, for every 10 patients you have to admit 2 of them, otherwise we won't give you new shifts. So you have somebody interfering with even how you manage your patients. Yeah, yeah. And even just the human rights, the issue about emergency care. Right now, if you are to get in an accident, the first place, God forbid, you'll be taken to is a public hospital. Why? Because the private sector will first of all ask, what is the deposit? Then what we saw even in senior doctors during the COVID being detained for 6 months in some of these private hospitals because they're not paid for the bills, or some not accessing ICU because they have to pay $500,000 deposit. Yeah, those are rights denied. Yeah, and here's the poverty and debt. You've heard about the issues of people selling assets to cover for healthcare, or even being referred to India. 10 billion shillings a year leave this country for seeing private healthcare outside there. Yeah, that inequality must be corrected. It's very, very important that even if life and systems divide us on anything else, we can't fight all inequalities, but on the right to life and right to care, There should never be a time when a child of the poor will have to die from malaria because he could not afford to go to a private hospital. And we have to fight back on that. And also understand, as I keep on saying, that privatization doesn't serve the interest of the public. It has never served. It is purely a profit thing, and it's not even, and has worked worse for the poor. In the US, you've seen some of the best John Castles, they are even doing separating their streams on one end. And then look at the black areas and black states and the black towns and inner cities, the kind of the healthcare they receive over there. You can, same way in Kenya, you see some of the services being received in the high-end private hospitals, and then compare that to women literally dying, giving birth in the local private health centers and clinics. Yeah, we hear about the UHC. UHC, the most important thing about UHC is that nobody should suffer financial crisis in achieving the best healthcare. How do you want to survive that kind of financial crisis, avoid it, when every time you want to have a chance at life, you are being pushed to private? And then private guys will always invest more in the high profit areas like curative. They have to invest in MRIs, CT scans. They never come talking to you about nutrition or hand washing or deworming, the low-lying fruits of preventive healthcare. Yet we are being told that we need to be pushing towards the preventive healthcare, employing almost 100,000 primary health promoters. Yeah. So we insist that even in the absence of corruption, privatization should never be considered in service provision. As Kenyans, we must say no to this idea of providing private solution to public social service failures. The role of a government is to provide the things they promise in the elections, what we pay taxes for, without pushing us to this other person who is just sitting there to collect the profits. Those are my references. Yeah, so that's my presentation. I hope that we can have then an enlightening uh, discussion around that. But I'd like to urge all of us here that let us push back. You've heard about the Minister of Water went to the UN and said that water is water resources in this country. Sooner or later, we are going to lose even that life. So I want to call to action to all of us here in our areas of influences, that may we all stand up and defend the last right that will grant us what God promised us in life. Thank you.
Thank you so much, Ms. Kala, for your presentation and just for taking us through just what's going on within the health sector and why there is this sudden push for privatization. I think our participants can, based on the presentation you have made and just based on Kwame's presentation on the economics of privatization, are in a better place to make a good judgment on whether or not privatization is the way to go for us as a country. And also just seeing the comparison with countries that have tried privatization within their health sector, and just seeing the challenges that they have experienced and where they are with that concept of privatization. It just gives us a wake-up call that, well, the conversation on privatization is not a conversation that should just be left to government. It's not a conversation or a decision that we as Kenyans should leave for government to make. It's something that we must be part of. We must all have our thoughts and views had on this issue of privatization, because at the end of the day, we are the service receivers and they are the duty bearers. So as duty bearers, they owe it to us to ensure that we are having an effective and accessible service delivery. And if they decide that the privatization is what will make us receive that, then we need to be part of that conversation so that we know what we are getting ourselves into, and also just be part of that whole process. So that said, I think there is a very, very interesting conversation ongoing in the chat box. And at this point, we will be going through and just having our panel respond to the few questions that we have. But before I do that, I would like to give this opportunity for anyone who would want to unmute themselves and just ask a question. I would request that you use the hand raising bar. You could use that to raise your hand, and then we can have us, the panelists, respond to your question. So you can just raise your hand, and then we'll give you an opportunity to unmute yourself. And then after that, we will go to a few questions in the chat box. And for those whose questions will not be responded to because of the constraint of time, we assure you that we will have a response to you either through email if you registered, but we will try our level best to ensure that we respond to all the questions. So a guest by the name Why Not? You can unmute yourself and ask the panelists your question, and then we can proceed to and if anybody if anybody is if anybody would also like to reiterate their question in the chat box, please do so, and let's have this conversation. So why not? Please unmute yourself and ask your question. Adrian asks to Dr. Miskela if there is a bill and a possible sponsorship by KMPDU or Kenya Union of Clinical Officers to force medical covers provided for civil and state officers to be only claimed in public facilities. And he reiterates, or maybe a bill in the works. So he's asking if there is a bill or if there is a bill in the works by either KMPDU or Kenya Union of clinical officers to force medical covers provided for civil and state offices to be only claimed in public facilities. And then there's a very long trail by Dominic. He's just giving on the comment on he's giving his comments on the economics. Not really a question, it's just a comment. And then we have of course, Adrian, Kwame had responded to you, so we'll go to Dominique. The market solutions for private healthcare have worked in accessibility of drugs through private firms selling wholesale drugs. The private sector should approach the transparency of prices to improve price sensitivity and give patients better choice in the market. I guess that's just a comment. So I'll have Kwame and Dr. Miskela respond to those three questions as we try to see, as we go through the other questions. So I'll start with Dr. Miskela, if you can respond to the three questions. Thank you.
The first one is the issue around sponsorship of bills for compelling public officers to go to public hospitals. I agree with you. That's something that we are willing to work on. If we can partner, we can always shout our emails, and we see how, because as doctors, as healthcare providers, we are in the kitchen. And we are saying that there's a problem with the food we are cooking and providing it to healthcare workers. Yet in all this, nobody seems to be listening. Yeah. Why? Because the very, very folks that are supposed to be making those policies and changes are improving on what we are serving Kenyans are getting it somewhere. In fact, the other day, somebody gave me an analogy that I really liked. That it can't be that you are a baker who has a bakery, and every time you make bread, you want to sell to the people in the market. But when you and your employees want to have breakfast, you buy bread for the next show. That's what you are doing to Kenyans right now. That the government and government officials are offering services to Kenyans that themselves they won't partake of. They'll go somewhere else. So yes, we could compel that, but of course, you know the response will be the same. That if you go to the same parliament where the same people are doing that, then we'll even see the light of day. But we can try on that partnership. Yes, the issue around privatization also helping on the challenges of the county government. Yes, the evolution has come with its challenges, massive one for that problem, for that matter, because governors thought that healthcare is supposed to give profits. They thought that when they see healthcare, they see these large hospitals having profit. That's the same thing they're going to experience in the counties. Only for them to realize that as a social function, healthcare is one of the big spenders. So, and they are seriously loss making, and they have to make losses because the moment a public social function is making profit, then there's a problem. It means that somebody is not caring about the poor and the vulnerable. Yeah. So I'm still trying to see how this privatization is going to be helping the situation. But as I said, that structural failure to invest and improve the public healthcare and even allowing the evolution to crash, you've now seen that almost how many months counties are not receiving their money. Nobody cares about how they're paying their healthcare workers. Nobody cares how the drugs are being bought or even reagents to push you to private intentionally. So let's not glorify that intentional breakage of the public health system. We must fix it.
Dr. Miskela, and of course to probably me, I think, we are being told, name one country that has UHC that doesn't suffer from longer waiting times for chronic illnesses and financially straining on the budget of their country. No country operates UHC without higher premiums and higher taxes. So Dr. Miskela, if you could take that. And then there's also, still Dominic is saying, name a government that has come up with a drug or is due to private sector investment in coming up with demonetization of private sector in the health sector is unjustified. So yeah, Dr. Miskela, if you could have a go on those two questions, then we can wrap it up.
Okay, thank you. I'll start with the last question around any government that has come up with the drugs. Most of these companies, the private companies, they invest their money in coming up with those drugs. And that's why the government put in place and WHO put in place the moratorium for the period that they use so they can recover their money. I don't think that these private people come up with this drug because they love you so much. They're in it for business, and there are laws put in place to ensure that they recover their money before the drugs are opened up for other companies to produce. Even the COVID vaccine, the amount of incentives that the money that US government pumped into private businesses, only for the same people to come and sell the drugs to the vaccines at a very high rate. Until now, we had to make noise around the vaccine apartheid. So it's individuals who have to invest in those things, and there are systems put in place to make them recoup their private. And nobody's demonizing private sector. We are saying that they have their role to play in coming up with those technologies and all those farmers and the drugs and everything. But when now they want to come into provision of the service itself, then we have to push back. We have to say no. Nobody is complaining about who is making the laptops or the chalk or the textbooks. We are saying that we don't have to send our children to public schools, to private schools for them to pass exams. Nobody is complaining about who is manufacturing the taps. But if you have to buy water in a bottle because the tap can't give me clean water, then you have a problem on that. Okay? So that's what we are trying to raise around that. On the issue about the UHC, it's true that the UHC has to be financed in all those components of structural buildings, putting systems, bringing drugs and the human resource. There's a very, very important component of the financing. And Kenya has to decide whether they want a socially funded product or tax-based. Clearly, based on whatever is being done in the reforms around NHIF, we are going for the social aspect of it. The challenge and the contradiction is that even as we are being told that NHIF is going to be 2.5% of gross salary, or it's going to be compulsory and all that, that investment in public healthcare space is not there. So that you're going to be mopping all these funds and you take them to somebody who's going to be carrying them for profit. Can you imagine if you have a system whereby almost all the level 4s above are owned by foreign interests? They will just be collecting all the money and shifting it back to their country. Yeah, and that's why at the end of the day, we have to put a system where that even if you're going to have UHC, we're going to be using that money to improve our system. We can only get better if we improve our own rather than borrowing from outside. One. Two, there's the issue that UHC is more than just curative services. There's a huge component of preventive, the vaccination, the health education, the nutrition, the clean water, and that. Nobody in the private sector is going to invest in that, because a private profiteer is going to be focusing more on the high yielding areas. It's a common sense business that if you're going to run a business, you're going to invest more in areas that give you more money, more returns. And where is it? In the curative services. Nobody's going to start doing screening, walking around doing screening in the villages, a private guy. See that? So for us to enjoy the benefits of the prevention, and I know prevention is cheaper and better than cure. For us to get those benefits, then we have to move back that responsibility to where it belongs, right at the door of the government.
All right, thank you so much, Ms. Keller, for your response and for your comments. Unfortunately, we will not be able to have Kwame respond to your questions directly, but we will try and make sure that we find a way for him to respond to your questions, either through email or we will reach out to Linda and I think Dominic, who had a few questions for Kwame. So what we will do is we will give an opportunity to Dr. Miskela to give us his closing remarks on just this whole concept of privatization. And then, yeah, we will give a way forward based on that. Dr. Miskela, your closing remarks?
You're breaking. What did you say?
Sorry about that. I'm saying we would love to hear your closing remarks on just this whole concept of privatization as we bring this webinar to a
Well, I
close.
don't know if it's my internet, but I guess you are saying that I should give the closing remarks, right?
Yes.
Thank you. Oh, so I know that in this meeting there are various interests, the people from the private sector, public sector, and all that. Yeah, and that's the only sense about the debate. Nobody's demonizing the private sector. Whatever we are saying is that let it be private by choice. Let people decide to go to private because they have chosen to. They want to go there. Let nobody compel us. Let guy not come up with this secretive and ideas and try to force people and compel people to go to private. Right now, people are going to private purely because of the fact that if you want to be seen faster, if you want to be moved from go buy the drugs, have to come back, go do this test, come back, they're going there because of the convenience. Why can't the public hospitals offer the same convenience? Who is this individual who is out investing government? Days of your Kenyatta Hospital used to be the place across the road from Nairobi Hospital. They used to refer difficult cases to KNH because KNH had the best doctors, because the best doctors must be paid highly. You can afford them. Public. Get that? But right now, we refer backward. We're now referring to private. What has changed over the years that the best doctors are now being paid in private, the best equipment are found in private, best drugs in private. Something must change because as a union, as I said from that, that while we know that there's a 1, 2, 3% that can afford that private comfortably, we know there's a 97% who there's only 90% that can afford it, and another 7% who have to sell something to afford it. That's the voices we are speaking for as a union. Thank you.
Thank you so much, Ms. Keller, for being here and for just helping us unpack this concept of privatization. I also want to say a very big thank you to our participants for making time to just be part of this conversation this morning. And I would like to remind us that the Institute of Economic Affairs is a membership organization, and we would invite all of us to go to our website and just check what our membership entails. And you can reach out to our communications department, that's Michelle Onditi and Oscar Ochieng, and they will be very glad to guide you on how to join our membership family. And also tomorrow at 2 p.m., if you have been wondering whether or not Kenya is broke, as is being indicated, we will be having a webinar on whether or not the government of Kenya is broke, and we will be examining government of Kenya's fiscal data up until March 2023, and based on the analysis that has been conducted by the Institute of Economic Affairs, we will be able to tell you what that data tells us and whether or not the theory that we are broke as a country is actually true. So please spare some time tomorrow at 2 p.m. and join us as we have that conversation. So that said, I would still say a very big thank you for making time, and we appreciate you, and we appreciate that every time we have a webinar, you always make time to join us for those who are coming a second, a third time. That said, we wish you a very beautiful afternoon, and God bless you all. Thank you so much.